Hello, so we are going to continue with the last part of our symposium. And now we are going to have a discussion panel. And as part of this roundtable, we have the immense pleasure of talking about intracranial pressure pulse as a vital sign. So now on this panel, we are going to have Dr. Sérgio Brazil as the moderator, Fernando Gomes Pinto, Salomon Rojas, Carlos Eduardo Nassif, and Nelcisa Noncolange. I would like to give the floor to Dr. Sérgio Brazil, who is going to lead this roundtable. Hello, Sérgio. Thank you very much. Good afternoon, everyone. Can you hear me well? So this is being an excellent event. Congratulations, Professor Colombari, and congratulations to everyone involved in the organization. So I have been going from hospital to hospital using my headset. So it's a beautiful tribute page to Professor Mascarenhas. It's very much deserved by him. So I am just a doctor now. I have only a PhD, not still a professor, and I have a pleasure of having here 4 colleagues with long experience, very capable, 2 neurosurgeons, 2 intensive care physicians, and 1 neurosurgeon and communicator. And so we are going to try. I don't know how much time we have. Please let me know because we're slightly late. I don't know how far we are going. And Kolobari, if you could please tell me whether we should go to 5:30 or if we have any more time so that I can moderate. Let's keep the initial time as proposed 15 minutes. We have Dr. Nilsi Zenan, a neurosurgeon with wide experience in pediatrics. We have Dr. Fernando Gomes Pinto, also a neurosurgeon who works a lot with hydrodynamics. And Drs. Carlos Nassif and Professor Salomon. Dr. Nassif is the head intensivist of Hospital 9 de Julho, and Professor Rojas is the head intensivist at the Beneficência Portuguesa Hospital in São Paulo. We have different people with different experiences, but in their understanding about brain compliance, but I think that they're going to complement each other. I want to make this very interactive. We have heard lots of technical content. And now what we would like to hear from you is your practical experience and the use for that. So going ladies first, as usual. So Dr. Nilsi, I thought of provoking you in terms of you going first, describing what you do. And I know that you knew Professor Sérgio before. You can tell us a little bit about that. And also to mention a situation and that where the understanding and the use of non-invasive intracranial pressure monitoring, whether it was very valuable in your experience. Good afternoon, everyone. Congratulations to the excellent organization. I could be with you throughout the day between one thing and the other. It was really fantastic. I had the privilege of meeting Professor Sérgio Mascarenhas one Sunday afternoon at my home, and he was already very excited, very enthusiastic, and he lived ahead of to his time. And he asked me, Nelsie, I imagine that we would be able to detect extracranially how the brain is operating inside and how pressure works. I have to admit to you, the idea seemed fantastic to me, but I didn't see how I could enable this for him in practice because he was really after it and he was sure that he was going to get there regardless of how we would do it. He was sure that he was going to be able to do that. So I learned to admire him right from the beginning. And we were talking about two things, about the NGO, Neuro Kids, for us to provide care for those who cannot afford the same quality that we provide for paying customers. This was also another of his dreams and my dream too. And the NGO Neuro Kids came true. But the second step to turn his dream into reality was done by Gustavo Frigeri, who could translate into practice his idea, and I didn't have that capacity. And they, using the lab, human and animal aspect, they combined everything together once the project was ready. And in its initial phase, I had the honor of having a child, very complex, very difficult management, a child with difficult to control hydrocephalus, many surgeries, multiple hospitals, multiple approaches. The child had already had papilledema with intracranial pressure that was reversed with the external shunt, but she didn't have papilledema. The CT scan was almost normal. She had a psychologist, neurosurgeon, and in between the headaches, the child had a normal curve. And during headaches, we were able to really identify P2 greater than P1, and that's why we decided for a surgical intervention. So this complement of the monitor together with the clinical aspects and imaging, I think is something that we want to do every day for all patients so that we are more confident to manage the patients, and whenever we are not so sure about the clinical status and are still wondering, and then we have two devices like the clinical parameters and the monitor, so that we can become more pragmatic. And I'm really confident whenever I see an abnormal wave to make a more accurate and faster decision. Thank you very much. I find it interesting, Dr. Nicholas Rabello, on the first talk of the day, he talked about solving a tie. And then we take radiological images, radiology tests, and sometimes you can't relate the two things. And then we have a dynamic tool to solve it, to untie, and to break the tie. And then it's interesting to see that with that regard, a good idea or a discovery fell in the hands of the right people. Note that I work with neurosonology, and neurosonology or ultrasound in neurology was the first utilization of ultrasound in medicine way back when in the 1940s. It was a huge device taking up a whole room or whole home with very poor quality image. So they left that behind, and it took almost 50 years until it became reality. So this was the idea of a brilliant mind that fell into the right hands. So congratulations to all the organization of the company that got the discovery and turned it into a product that today is in our hands, and that will make it possible to expand the applicability from faraway places in Brazil to major centers. So sometimes I say, I don't know whether it's mine, it's someone else, it's probably someone else. But I think that discoveries become very obvious after they've been discovered. Until then, it's a very difficult way. So the professor had the idea, he thought it was possible, and he really was able to turn this into reality. It's beautiful. On the same idea, I am going to question Dr. Fernando, and I think you're in India with us. Is that right? No, I'm just joking. It's because of your background. Dr. Fernando, you have lots of experience with brain hydrodynamics, with hydrocephalus and brain strictures. So where do you see the applicability in these pathologies? Good afternoon, everyone. Congratulations on the event. I'm very happy to be here with you. So I met Professor Mascarenhas, and I had the chance of being with him in a project that became true, that was called Neurolife. And even I gave the interview to Giovanna to show everyone because it's really a jewel. I work with brain hydrodynamics, which was the subject of my thesis to become a full professor. So it was very interesting because Professor Mascarenhas expressed, uh, so he became sick and he really felt it in himself. He was in the shoes, and we really do we need to break the barrier of the brain to understand what's going on in terms of brain compliance? So here talking, and then once you insert the valve or the shunt, and so all the knowledge that he had, he focused that in terms of finding a solution that really revolutionized the understanding of brain pressure in a non-invasive way. So I would really strongly recommend that you should see this interview that is in a YouTube of the Brazilian Society. To study patients with hydrocephalus, so usually have a spinal tap to take CSF, measure pressure, and clinical analysis. And then there was a gap. How can we study intracranial pressure without drilling through the skull? So whenever I have patients with normal pressure hydrocephalus or intracranial cysts or pseudo tumors on the brain, I use the monitor or the sensor as a routine. This is because in addition to imaging information like a CT scan, MRI, or even pressure values through the spinal tap, I want to understand the patient before surgery, whenever they're taking a medication, whichever medication they are taking, like topiramate, or even patients with normal pressure hydrocephalus. And we know that with the programmable valves, I want to understand a little bit more than just the clinical picture of the patient. But I'm not going to break his physical integrity just to have information. So yes, we have been using this to understand what happens to the patient to establish a correlation. Oftentimes recommending a surgery or counterindicating an imaging test or recommending imaging test today doesn't really make much sense, at least from my standpoint in understanding university environment. If it is possible in real time, it's not something that you order. I can do it. I'm there in my office or just next door. You train someone to do that, and in real time you see P1, P2. This will help me make decisions. So in fact, the professor's idea was really revolutionary. In a very short time span, we are able to solve that. And many people ask, how can you do that? So you're just taking the pulse of the temporal artery, and we know which is not quite like that. I went to the Porto University to see the work of Professor Celeste with invasive and non-invasive ICP. And so today I do this with all my patients. So it's very good propedeutics as patients undergo clinical assessment. I measure blood pressure, check the pulse, or even in talking about neurology, so a fundus examination. So why shouldn't have this real-time information in the office? So in the outpatient setting, we've been using it a lot. It helps us to program the valve, to recommend a revision, or so sometimes there was a surgery and we're not really sure whether the pressure is higher in the brain. So the next step is to take this information to everyone, especially in universities, and people who understand what we are saying, and then so on and so forth, thereby broadening our array of action. So it's very primitive for us just to look at a CAT scan or MRI. And ideas overflow. So in my understanding, very soon ambulances and pre-hospital care. So if I check blood pressure, if I check pulse and I check mucosa, if I have the capacity of putting on a sensor that will give me an idea of that, it's kind of obvious. This might define management, and in neurotrauma, time is life, is neurons that are preserved. Great. Now to cranial strictures. So when the skull is fused in children before time and there are deformities, so you had mentioned, and I was wondering, does the wave stay the same or not? What happens? So in the cases that I have been operating and using the sensor, we are still gaining practical knowledge. What is that going to be translated into? So can I see P1, P2? And then after the tissues heal, I can see a change in a pattern. Do I need this information? Isn't it kind of obvious, clinically speaking? Well, I don't know. There are situations when, for example, there's a patient that has been operated already, and maybe the result, not just cosmetically speaking, the healing is not so good. I'm not really sure. Family is wondering, should we reoperate or not? Much more than just looking at what happens, that we can see in the X-ray. I have real data that involves no blood, because they're babies, and then you need to have someone prepared who can extract the best material. But all of this will guide my practice, and I have been doing it as a routine precisely to gain knowledge and to include that in my practice. This is translated into assurance to the family. And we don't treat just the skull. We know that there is something complex happening in there. Sometimes we minimize it because not every patient has an extensive neuropsychological assessment. So it's very easy for us to say that there is no abnormality in neurodevelopment, but we know the brain compliance is sometimes compromised. The development of neurons will be related to that.
Well, the key word is serial monitoring. You are ready to observe your patients and check, because we are seeing a dynamic physiological number. And when we are dealing with it on a daily basis, we see the wave doesn't tell a lie. We really have to understand what's behind it and think about our possibilities. There are 3 volumes, so blood, brain, CSF, and the interaction is highly dynamic, especially when the patient undergoes surgery. You can see the patient, and you can monitor with a method that can be repeated at any time to any patient. This is something really amazing. Let me ask our intensivist to speak, and then I'm going to ask you different questions. Let me ask Professor Solomon Rojas. He is widely experienced with the use of this method after heart surgery. Patients are maintained in extracorporeal circulation. They receive high doses of sedatives, each of them with a vasoconstriction or vasodilation function. Professor Solomon, using the system and monitoring intracranial compliance, he knows what sedative has been used during surgery, right? Good afternoon, everyone. Really an amazing event and a very deserved honor. I haven't met him in person, but Gustavo introduced the method here into the center, and we started monitoring the patients. There were some post-op cases, especially of aorta aneurysm surgeries that have deep hypothermia during surgery, then reimplant of vessels. They are major surgeries with extracorporeal circulation, as you've pointed out. And in addition to that, they have anterograde brain perfusion, cannulating through the brachycephalic vessel. So these are patients that really behave differently. I used to have a post-op care. They had seizures and other problems. And patients like that, take them to CT scan, transfer them. That was all too complicated. So Gustavo introduced me to the method, and I just got enthusiastic about that. I really liked monitoring patients and use low-risk technology. So use non-invasive ICP. Convulsion after post-op. I knew the patients had that. So the patient had a seizure, we treated it, used the non-invasive ICP monitoring, P2 greater than P1. And I kept, Gustavo, this is curve morphology. It starts to get widening if there is anything wrong. I told him that. So I reviewed PO2, the gases, blood gases, if I needed to sedate further the patients. And it was interesting to observe the cardiovascular surgeons also ask a blood pressure of 110 maximum to avoid bleeding. So I've realized that these patients need high pressure. And I was learning, you see, as all of us have learned from the method. If we improve the pressure, we had an improvement of PaCO2, and once the curve got normalized, the patient had no more convulsive seizures. And I started treating the indirect sinus of intracranial pressure. And once the P2 is normal, I prepared the patients for extubation, and the patients could wake up with no deficit, just got weaned and well. So the surgeons that operate the patients, I started monitoring all cases like that. And this is a surgeon that has many aorta aneurysm surgeries and complex cases like that. So I started monitoring that, and I always tell him and say, ask Salaman what's going to be the pressure to be used. It's not 110. It results from the analysis of pressure curves. Not only this patients, in neurocritical care patients, I just do it immediately. Ischemic stroke. I believe that this is a method that cannot be put aside. It's a method that has to be used. I don't know, he's breaking up. I cannot hear him. Yes, we cannot hear him. Maybe something concerning the connection, right? Yeah, okay. Now he's back. And you are on mute. I can recall a Congress when I presented the cases in 2017 and the results of non-invasive ICP, I was widely criticized. And now those that criticize me are using the method, and that's okay. I believe we can have good results and better monitoring of our patients. Exactly. Whenever anything new is like that, you have the early adopters, those who fall for it immediately, and there are those that need to take some more time. You really have to base our actions and procedures, indicate them or not, based on scientific evidence, of course. But performing a research study is the result of wanting to inquiry, wanting to know something else. I used to monitor them using CT scan, right? Measure the optic nerve sheath and compared, and also confirmed that it coincide with the ICP, non-invasive ICP measures. Yes, the optic nerve sheath diameter in acute cases, it makes sense. It does have an excellent temporal resolution and it's quite useful. And it's a very complex case because it is brain that may be with edema because of hyperperfusion. Sedatives may cause cerebral vasodilation, and the patient might have blood hypoflow, for example. Conversely, if there was an overdose of some IV drugs, that would be the opposite mechanism. But who is going to deal with that? Professor Salaman, poor thing. Then the brain gets edema or flow goes down. How can you really strike a balance? Today, I went to an ICU. They have very few resources. So MAP or MAP 50 to 60. I said, oh my God, I looked to the monitor and the MAP was 80. Fortunately, the goal is not being met. If you check brachial blood pressure and the carotid pressure, which can be up to 40 millimeters below brachial pressure, and want to have it at 50 to 60, well, I don't know what criteria were used, but we have to rely on methods to have a customized care and monitor severely ill patients. And they can easily have a decompensation. So let me invite Dr. Carlos, and Carlos Nassifi will tell us about that because he likes to talk about sepsis. So thinking about compliance, we've heard from patients after a cardiac extracorporeal cardiac surgery and extracorporeal circulation. Is it important to monitor intracerebral compliance in patients who are not neurological case? Let's say the patient had COVID or SARS or a heart case or lung, all the other diseases that may also decompensate neurofindings, and the patient is under mechanical ventilation, sedated, and we don't know what's going on with the brain. And then say, well, how come the patient is not waking up? Well, the patient is compensated, so what's wrong? So Nassifi, tell us more about that. Oh, hear me? Yes, we can hear you. Now we cannot. He has muted himself. You are on mute. Good. Now we can hear you. I just heard about Brain for Care and I was very skeptical. It was 5 years ago. And Professor Sérgio was someone who would charm people. Can you all hear me? Yes, we can hear you. There were two things that made me believe in the method. First, the empathy I felt with him. You see, someone just so humble, a dreamer. And once he said something that really made me believe in him. He said, he told me why he hadn't sold Brain for Care to a large company. He said it had been asked, and he could have made money with it, could have lived quite well for good. But he said something, and I still recall it. Science is not at the service of a scientist, but rather at the service of humanity. So I believe he has developed many projects in addition to Brain for Care, but something to be provided to everyone at an affordable price to everyone. And this is something wonderful in such a capitalistic world where people just care about money much more than helping, providing care to patient. I brought the method here to Hospital 9 de Julho because it was easier to understand how the method worked. And we have a unit of trauma with neurocritical patients. So focused on that, because I've been working with them since the 80s in my medical resident years, and then in the trauma unit at University of São Paulo. There were some very bad times because we didn't used to have good pre-hospital care in the city of São Paulo. Patients got to us and they were very severely ill. And there were people who were not well trained to provide rescue service to patients. So we started training the fire department, paramedics. That was in the 80s. And we know how things got so much better. So at first, we focused on trauma cases using the device and always validating results against invasive ICP at first. We have TPO2 for neurocritical patients. We have transcranial Doppler. We have electrocardiogram, electroencephalogram. So we could really understand how the device, we've learned how the device worked and validated it to make sure that the information was reliable and we could use the equipment on our daily practice. We started first by confirming what was shown. The pulse waveform of Brain for Care was similar to that of invasive ICP. It was immediately confirmed. We kept on studying and we realized that it was extremely reliable. We used a cerebral microdialysis there, but there are just so many bad things going on in the brain before ICP goes up. We used to analyze lactate, pyruvate, and the levels were abnormal even before ICP. So when we start approaching patient and treating intracranial hypertension, we've already lost time. And this is something that I compare against patients with infection in the ICU.
So when it's difficult to treat them, morbid mortality is higher. And we want to treat infected patients with sepsis. We want to treat patients before they are too bad. So with PO2 in the penumbra areas, if you don't do it, something very fast, this will obviously increase local reactions, but you lose cells and you worsen the damage. And then the quality of life of patients will be very much worse. I had a very fulfilling experience. I had a very severely ill patient with PO2 when the surgeon thought that it was too low because it was malpositioned. And the patient had normal ICP. And so let's take out the sedation. I said, hold on, wait a minute. And assessing with Brain for Care, there was huge abnormality. And then we used the method, something that was mentioned before here. we did like a PRX with brain for care, and then when mean pressure was 10, and then PaO2, and then we could do something. And there was an error in terms of the placement of the catheter. And the intracranial pressure and compliance were very poorly controlled. So we took management measures to control that. We controlled that with the Doppler. And then after a week, the boy was extubated. He was a little bit frontalized because he had 2 frontal traumas. But considering what happened, it was a victory to keep him alive at good conditions. Very fulfilling. And from then on, we started seeing that there are many more things that we can do than just using for the adjustment of measures in neurocritical patients, something that goes well beyond that. In some ICUs, there is a very, very wide range of pathologies that cause neurological disorders, loads of them, many. And the older the patient, and if already have some neurological abnormality, it makes matters even worse. So we have seen here, and we practice good practice in the management of patients with severe height respiratory failure. And then hypercapnia can cause many abnormalities and has many consequences. So we could hurt the patient less. At the same time, it protected the lung and it caused less brain problems. And we do that on the bedside. And then if we have ETCO2 to find a midterm where there's a good reserve for the patient, and then it wouldn't cause so much problem, and thereby preserving the patient's brain. And after 4 years of study, we started going towards other directions. For example, in differential diagnosis of delirium. The patient had a severe condition, sepsis, septic shock. Patient doesn't wake up. It's very common to say, well, it's the patient is older, comorbidity, severe disease, lots of sedation, will take very long to come back. And there are a few rules in intensive care, which are kind of they're kind of unanimous. When you want to optimize the systemic status, we believe that the mean pressure of 65 can be good. But this is not always good. So we did this with patients who would not wake up. And then more recently, the patient had gone through a septic shock, and the patient had some vasoactive drugs, and the goal of reducing drugs for APAM ideal. I use the brain for care in a patient, and with 70, brain flow was very poor because P2, P1 was less than 50, the ratio. And then we titrated and increased the pressure. We saw that the best pressure to perfuse the brain, as confirmed by the Doppler, was a PAM around 80. So at 80, he got better. Look at the difference. He went from Glasgow 6 to Glasgow 10. Thereby showing that we have in our hands something that is very helpful, that we should always assess the brain hemodynamics, not just the systemic hemodynamics. We have parameters with good diuresis once the patient is resuscitated, if they don't have renal failure. But the brain is different, and this is closely related to length of stay and time on mechanical ventilation, and the evolution after discharge. So now this leads us to think that the device way back when we were think about patients with neurological disorders, it's much more difficult. And in seeing the talks here, the method is so accurate, and something that we saw here is proven by literature and by other colleagues too. With the same conclusions that we came to here, others have come to as well. So this is a very valid method. It has come to stay. And I think that the fifth vital sign is something that it has come here to stay. Uh, if you have a critical patient, you will not resuscitate unless you have a bedside monitoring of the brain dynamics. To me today, ICP today, I have nothing in the hospital, only ICP. Well, but for those who can, when we had that case here that I and Gustavo oversaw, was a patient with very terrible TBI, Glasgow 3 on site on the scene. P2, P1 was 1.4, 1.3 ratio. And then we did a CAT scan. He had a diffuse swelling and the primary neuroprotection measures. We didn't put an ICP monitoring, and everything was based on the information provided by Brain for Care, whether the patient was stable, and we conducted many assessments every day, 6, 7, 8, because it was a very critical case. And this patient left without needing ICP. We never used the OR. And then the boy, 9 days later, was outside the ICU, extubated, and went back to absolutely normal life as if nothing happened. So this saved loads of money to the hospital and the insurance company. So along these 4 or 5 years, we have an assurance that the information that the device provides, they're very, very reliable. And everything worked. So the fifth vital sign, this depends very much on us who believe in a method. And for intensive care, I am sure that this is going to be very important for us to have systemic resuscitation without thinking of brain resuscitation. So it will be a brain resuscitation first, because then if you resuscitate the brain, the rest of the body will resuscitate together, but the opposite is not always true. Well, this is really great. And even confirming what you were saying in the work that we did assessing 50 severe COVID cases, it was very much that, looking to the multi-parameter monitor and looking there, patients were compensated and assessing with transcranial Doppler and sensor. There was brain swelling and there was abnormalities in the brain hemodynamics. The patients that had circulatory delay, according to the Doppler, with large P2 over P1, all of them died. So then trusting on the multi-parameter monitor, we would have information that would make doctors more at ease. But if you're not monitoring what's going on, there's a high likelihood of you're missing events. Thinking of all of this, we have 10 minutes. Many discussions with colleagues from all over, thinking of the system, and the company has suggested potential uses and essential uses of the system. And we can see very well acute brain injury as a major field with ventilated, intubated patients where there is no neuro check, which is very important to monitor. And also to help anesthesiologists after surgeries, help to neurosurgeons And Dr. Nilsi has talked a little bit about that. And I'm even going to ask Fernando, in specific cases, do you see any potentials that when to recommend or not recommend or delay surgery? I can give you a very practical example of my everyday practice. The patient with a pseudo brain tumor with a cleft in the ventricle that are telemetric monitors. And then what's better, worse, the telemetric monitor can give me the curve and the value, but it has an expiration date. So all these resources are complementary. The brain for care I can use forever. So even if there is a critical time that I take it home, the possibility of doing something that is relatively invasive as in the ICU, this can be translated into knowledge, numbers, and data. Sometimes I don't know for sure because I don't have any images. I don't have much more than the clinical complaint of the patient in a situation such as that. But I need to know whether the brain compliance is normal or not, whether the delay or to get better, maybe it's taking too long and the response does not agree with what I expected in terms of the valve and its adjustment, because the ventricle is very small and it's practically collapsed. I might move to more aggressive surgeries such as bitemporal decompression. And fortunately, this is not done as a routine. So depending on the situation, this might help me to manage the case. And they will say, well, don't do it, or the patient has a complaint. I have exhausted all possibilities of adjusting the valve. I'm not sure whether the valve is working or not. And then I have an extra information that breaks the tie. And you have information that in the past you needed to follow your clinical intuition. And now you have some extra information, something palpable, very concrete that you can repeat as many times as you want. So in these conditions and considering these features, I gave you a practical example of something that happened to me. So you want to use a valve, and that is the problem. And where no one could say for sure whether the patient needed a re-intervention. Well, perfect. Working in the gray zone is the most difficult. When you're sure that you need to operate, that's okay. When you're sure that you don't have to operate, that's okay too. But the reality and the hard time we have is this. Sometimes I need to have a better assessment. So patient who had hydrocephalus and was operated, they have ventricle megaly. Ventricles never go back to what they used to be. They're bigger, and then patients that are readmitted whenever they feel nausea, headache, just because they have the valve, they go to the hospital, they're admitted. So they have very hard lives. And also in investigations of pseudo tumors, it's very difficult. It's as what Dr. Sérgio went through to diagnose HPN. They are diseases that are very difficult to diagnose and to manage. So everything, your testimonial is really great.
Let me tell you about that turning point that can be helpful in addition to image. This year in 2022, in our pediatric unit, congenital malformations, we know that in the public service, there are limitations for CT scan and MRI, of course. The resources are not readily available. How can we make a difference to that patient who comes? If you, do you send the patient home? Do you send patient for ED? If the curve is normal, we just feel reassured the patient can be home and wait for the image. If there is a yellow signal, or we can remonitor or order emergency imaging. If it's an abnormal curve and there are clinical manifestations, we are going to try to send the patient for the emergency department or immediately admit the patient into the hospital. So it's really helpful for screening patients in which we have limitation of resources, of sending patients to the hospital. So I think it also minimizes the difficulties for the family, sometimes ordering tests which are not necessary, or admit the patient when there is not the best case to do. So it really reassures us. And of course, if there is any question, we can always have the patient remonitored later, as we've heard here before, because it's readily available, it's not invasive, and you can repeat as many times as necessary. So this is the case. For example, there was a case that we interrupted surgery. I scheduled surgery for the next day, but then as there was a valve with external regulation, I opened the valve, placed the patient in the ICU. The next day, the patient still had symptoms, but the curve had improved. So daily monitoring has led to a performance of or interruption of an unnecessary surgery, just based on the profile of P2 over P1 ratio. And this is something that really makes a difference. That's great. Monitoring the patient is really what makes a difference. And this is why we can really repeat the procedure, and that means no invasion. Really amazing. It is a turning point to all of us. Well, unfortunately, our time's up. We could be on and on here for so long, but I think it was an extremely interesting discussion. And those who are here with us have got really thousands of ideas of potential applications. And that can be relevant to all of us, because anyone in healthcare can use the method and see results which are relevant for different management approaches. Thank you. Thank you all very much for sharing your experiences, for this richness of content. Thank you for being here with us. And now I hand it over to Dr. Colombari, who is going to carry on. Thank you. Thanks, everyone.